everyone. I'm Nina Collins here from Revel. This is our weekly recording of our podcast, Raging Gracefully. And once a month, we do a podcast with our partners at Alloy. So Anne Fulenwider is here, and we have a special guest, Pauline Maki, who rhymes with tacky. She told me, so that's how I'm remembering the way we spell her name. Anne is an Alloy co-founder, and Pauline Maki is an Alloy Medical Advisory Board member. She serves as a professor of psychiatry, psychology, and obstetrics and gynecology at the University of Illinois, Chicago, as well as director of the university's Women's Mental Health Research Program and senior director of research at the Center for Research on Women and Gender. That's a lot of jobs. It's very impressive. She's known for her contributions to the field of menopause and cognition. For 20 years, she's led a program of NIH-funded research focused on the role of sex steroid hormones on cognition, mood, brain function, and stress responsivity in women. Professor Maki's primary contribution to clinical practice is her research on the risks and benefits of hormone therapy on cognition and brain function. And she's also past president of the North American Menopause Society. That is so cool. Welcome.
It's a great organization.
It is
Thank
a great
you. Nice to be here.
Yeah, really nice to have you. That's amazing. I don't know how you've done all that. How old are you?
55.
Oh, yeah, you look young. Okay, I'm 52. You've done a lot more than I have, but very good to have you here. So we're here to talk about aging and mental health, menopause and mental health, and the role of hormones. And my first question I'm going to start with is I was thinking about this. Like, I know, so I'm on hormones, I'm on HRT or hormone replacement therapy or hormone therapy. And one of the reasons I went on it, my mom died of breast cancer when I was young, but one of the reasons, I mean, I mostly went on it for hot flashes, but I also went on it because I started to feel like the bit of evidence that was coming my way was that it might help with things like Alzheimer's prevention, and heart health and all those things. So, but I didn't go on it thinking, well, actually, that's not true. I guess I also thought it would help me a little bit with my mood. And I do feel now that I'm on hormone therapy that my mood is very evened out. I really feel like probably the drop in estrogen and then like whatever steady state I'm in, like I don't feel the waves that I used to feel when I was young. I mean, I think it's complicated to parse it all out, right? Because I think we're also generally a little more confident as we get older. There's all sorts of things going into it. But I am interested in, and I'm so not a scientist, but I am interested if you can explain a little bit, like, is there a correlation even between mental health and brain health? Like, do they work together?
Yeah, so it's a good question. So this is an important question for women in particular, because 1 in 5 women will be diagnosed with major depressive disorder in her lifetime, right? So that's mood problems, not only are impactful for people generally, but disproportionately for women, right? And we know that this difference in mood emerges at puberty. So this tells us that this is hormonally driven. Yeah. And there's all kinds of really innovative, cool brain imaging studies that show how puberty rewires the male and female brain differently. And it does so in such a way to make the female brain more predisposed to mood disorders. And so that's kind of a way that we can think about how mood and the brain, how are those concepts tied in our everyday understanding. And indeed, the brains of women differ from the brains of men in fundamental ways that contribute to their mood disorders. There's an hypothesis that I really like, which is this idea that our very, very low moods, and here we're talking about clinical depression, are a scar on the brain, that it predisposes us to a different kind of trajectory of brain aging. So our path toward aging in our brains will differ depending on whether we have a history of significant mood problems or not. And actually having a history of a mood disorder is one of the significant risk factors for Alzheimer's disease.
Really?
So mood is tied. Yeah. So it is tied to our
Anne and I look
scared. Like, oh no, we're screwed.
Yeah. And females comprise 2/3 of people with Alzheimer's disease. Right. And, a major unanswered question is, to what extent is this driven in part by differences between men and women in their history of mood disorders? And
God,
to
that's
what
fascinating.
and to what extent is that driven even more so by the fact that the menopause transition is a period of risk for major depressive disorder in women?
And do you think that the higher incidence of anxiety and depression in women in menopause is it clear to you, or that it's related to hormone shifts? Or is that something that's not proven? I mean, it seems like there's so much speculation, right, around all this stuff in menopause and aging. Like it's hard for me to know like what's really true and what stuff we just kind of say is true.
Isn't it?
Yeah.
How do you know what's true when there are these myriad sources of information? How do we sort out what's driven by science, what's driven by opinion? And personal experience is equally valuable in many ways, because what might be true for us may not be true for the masses, but it's real in our experience. So it can be quite complicated. But yes, I would say with a pretty high degree of confidence that the level of science supporting the idea that the menopause triggers depression in some women is actually very strong. It's a very high level of evidence. So it was a very clear research study that showed this. And basically what they did, and this is by Peter Schmidt, a phenomenal researcher from the National Institute of Mental Health, did a really clever thing. He took women who were now past menopause. Some of those women had had a new onset of a mood problem when they transitioned. Okay, so they did experience menopause as being a period of risk for their mood. Then he took another group of women who didn't have that experience. He put them all on estrogen, making them essentially kind of in a premenopausal hormonal state, right? So before hormones, so estrogen was re-onboarded. And then he created like a menopause, and he withdrew the women from estrogen, just told them to stop it. And do you know what happened? Who do you think got depressed? The women who had the history. That's right, Anne.
Yeah. Wow.
Exactly. And
well,
so,
and I'm actually like really stuck on this idea. So I've known for a long time that 2/3 of women get Alzheimer's, and it's one of those things that I spout and say like it's so scary.
It's 2/3. Let me correct.
2/3 of all people who get Alzheimer's.
That's right.
Sorry.
Thank you.
Only 10%. 10% of us will get.
10% of us will get Alzheimer's. Sorry.
Yeah.
Although my colleague just told me now that once we hit 60, we have we're twice as likely to get Alzheimer's than breast cancer. It's a completely different conversation. That was interesting.
No, you're right. You're right.
But
the base rate of Alzheimer's disease late in life is much higher than the rate of breast cancer.
Yeah, a whole fascinating thing. But the idea that the increased incidence of Alzheimer's in women may possibly be tied to our increased incidence of depression or mental health and disorders is fascinating.
Right. So that's one of the factors that predisposes women to Alzheimer's disease. There's a lot of speculation about the role of estrogen loss at menopause and what that might predispose women to. My own work, though, focuses on menopausal symptoms. So what does, in particular, hot flashes, and what happens when we have hot flashes at night? If they're bad, we wake up, right? And we have those night after night.
And that's right? I'm so glad you said that. That's actually why I ended up going on hormones, because my gynecologist kept suggesting it, and I was like, my hot flashes aren't so bad. And then I entered this period like 2 years after my last menstruation where my hot flashes got really terrible, and I finally concluded that the lack of sleep is probably just as detrimental to me. At least I was like, I think I have to go on hormones because I'm literally not sleeping and feel like a crazy person.
Right. And you don't need to be the past president of the North American Menopause Society to know that your brain needs sleep to stay healthy, right? So, but it's interesting. The field has really ignored the fact that women have this unique problem with sleep, which is that they wake up because they have hot flashes, right? 80% of women have hot flashes. And we know that sleep problems are strongly tied to cognitive disorders, especially Alzheimer's disease.
I didn't know that.
Right? No,
that's new to me. So sleep, there's a correlation between sleep problems and Alzheimer's.
Very strong correlation. And actually you can show causal associations between sleep deprivation and memory problems. You show this scientifically by taking a group of people, and half of them you force into sleep deprivation and half of them you don't.
Mhm.
and then you measure the change in their cognitive function and their ability to learn, to remember, or what they crave, the kinds of food you crave changes during sleep deprivation. The extent to which you react to something emotionally changes following sleep deprivation. So the association is actually thought to be causal. In women with hot flashes, they have hot flashes. Most women have them for almost 7 years, right? So that's a lot of sleep deprivation if they're having these night after night after night. So that's chronic sleep deprivation as a risk factor for Alzheimer's disease. There was a really, really important study that showed that just one night of sleep deprivation led to an increase in the proteins in people's cerebral spinal fluid that are associated with Alzheimer's disease. One night, and you saw an increase in these biomarkers. So sleep in Alzheimer's is a really hot field, and I'm afraid that it hasn't been linked so strongly to sex differences in Alzheimer's disease.
I have so many questions. I don't even know where to go. We don't have that much time. One thought is, first of all, a lot of men I've known have had a lot of sleep problems.
Mhm.
So I wonder,
They too are at increased risk if they have sleep.
Increased risk.
Yep.
You take a question from the chat before we go to hormone therapy.
Sure.
What if the past mood disorder has been treated, like with SSRIs? Does that help avoid a trajectory to Alzheimer's? Good question.
Unfortunately not. And I'll tell you why.
That's a
It's
bummer.
because one idea is because so few people with depression ever receive treatment. Right? It comprises such a small proportion of people who have had depression. And those who go on the antidepressants tend to be the ones with the more severe depression. So it's a hard thing to study scientifically, really.
Okay.
So anecdotally, though, I feel like, yes, everyone I know in New York City is on SSRIs, but
that's what I was about to say.
So I'm like in a bubble, perhaps, because I thought and then there've been a couple of articles recently about the fact that perimenopausal aged women are the most prescribed group. I'm going to get my grammar wrong, and Nina's an editor.
Interesting.
But
interesting
of SSRIs. So, let's say if you maybe didn't have depression before, you hit menopause, you immediately, day 366 after your last period, start on HRT or estrogen therapy, and therefore avoid some of the depression. Is that I'm going to make like 3 different leaps that you're probably not comfortable making as a scientist, but so then does that, so the SSRIs are not going to help you avoid Alzheimer's. Is the estrogen you're taking going to help you A, with your mood, and B, with Alzheimer's avoidance?
Yeah, so I want to separate out what's theoretically very likely from what we know scientifically. Theoretically, what you're saying makes absolute sense to me, right? We don't know this for real, because to actually answer that question, you'd have to take a group of people, randomize half of them to SSRIs, and then follow them for 25 years until they were at the period of risk for Alzheimer's disease, right?
Okay.
So we and that's the kind of data that suggests that SSRIs don't lower the risk of Alzheimer's disease, because it's confounded with all the reasons people use SSRIs. It's not a randomized trial. But what you say is correct, and indeed, my recommendation to women is very strongly to get treatment either with an SSRI, or if you think it's due to hormonal fluctuations, to go on an estrogen, which flattens out, Nina, as you were suggesting, your mood became more stable. It flattens out, estrogen flattens out that variability in hormone levels that contributes to women's vulnerability to depression. And so anything that treats that is going to confer some protection to the brain. So yes, absolutely.
This is good news for us. We're on hormones and SSRIs, I think. So I take both.
I have so many actual doctor appointment questions that I just will maybe spare.
I know. So I'm going to take another question from the chat. Is there a difference between night sweats and hot flashes as it relates to mental problems? I like the mental problem.
Oh, that is the $25,000 question to age myself, right? Anyway, yes.
We all know what you're talking about.
The answer is we think there is, and it's a really interesting question. So there seems to be something special or unique about hot flashes at night in their relation to multiple systems. So we see a link between nighttime hot flashes or otherwise known as night sweats, and both mood problems and cognitive problems. So those associations are oftentimes stronger than the association with daytime hot flashes. In addition, my good colleague, Rebecca Thurston, who's a professor at the University of Pittsburgh, has shown that there's something interesting about night sweats and cardiovascular disease. And so the literature is in your brain health is your heart health. So if you want to keep your brain healthy, you got to keep your heart healthy.
Wait, you have to.
I know.
Yeah,
you know that either. Okay.
No. You have to go back and explain that. But
yeah, sure. So we know that lowering the risk, especially of hypertension at midlife, can protect you from getting Alzheimer's disease. Keeping your cholesterol levels in healthy ranges can help to prevent it. Preventing diabetes can help you to prevent it. There's a lot of focus right now in the Alzheimer's field about maintaining good levels of blood pressure lifelong, and the importance of that for your brain, because you can get these small, what we call lesions, these small scars in the brain that are like tiny, tiny, tiny strokes. They're called white matter hyperintensities. And they actually confer a risk to Alzheimer's disease. And in my own research with Dr. Thurston at Pittsburgh, every week we look at pictures of women's brains, and sometimes you see these little white dots all over the white matter of their brain, and it's because they're having these tiny, tiny lesions, and that's so strongly related to blood pressure. So it doesn't keep your brain healthy if you have hypertension. So keeping your brain very healthy at this age, in the 50s, is key to preventing Alzheimer's disease. It's one of the most important things you can do, is to maintain really good heart health.
Okay, so let's talk about that for a sec, because that sounds really important, and make sure we're all doing all the things we should be doing. So do you recommend, what's your feeling about statins? Because of course, cholesterol goes up for some women in menopause. And I hear, like, in our community, a lot of different things about statins. A lot of people say, which I don't understand, that if you go on statins, you can never go off. But my cardiologist says that's not true. I'm on statins now because my cholesterol went up, and I went on a really low dose only 3 days a week, and I feel good about it. But I did a whole bunch of research trying to figure out if it was the right thing to do. It wasn't completely clear. I wasn't like an obvious case where I needed it, but I'm really afraid of having a stroke because my grandmother, stroke.
We want to avoid that. Yep.
So keep our cholesterol down, exercise, but what are ways, so just to focus on brain health in our 50s, what for you are the top 5 things you have to do for brain health in your 50s?
Yeah, I think for women, it's focusing in a targeted way about what the menopause related risk factors are and minimizing those. Okay. So if you have hot flashes and they're bothersome, not a hot flash here or there, which you can go untreated, but if they're bothersome, which they are for many, many, many women who unfortunately go untreated, get them treated, because it's going to not only improve your quality of life, but it's also linked to improved mood and also to improved cognitive functioning. And when we're in our 50s, many of us are at the peak of our careers, right? We're at our optimal, height of running whatever it is we want to do in our business lives. And we're the National Labor Statistics Bureau shows that we earn our most money when we're in our 50s. And so we want to be functioning at our best capacity. So why risk that to sleep deprivation? Why risk that to nighttime hot flashes if you can treat that? So, I'm a big proponent of treating the symptoms. There also appears to be a direct benefit of estrogen on the brain in terms of keeping the brain healthy. So even if you didn't have hot flashes, there's some data. That data is not yet strong enough to recommend estrogen to protect the brain outside of the hot flashes.
Okay.
But maybe for the women who have the mood fluctuations, right, because of that scar idea that I mentioned earlier, stabilizing, mood with hormones is also important. And then there's the kind of indirect stuff that makes a lot of sense when you talk to individual women, which is, let's say I don't have depression, but I'm going through menopause, and I'm like 80% of women whose mood just does get a little worse. I'm not depressed, but
Yeah.
I'm not my full self, right?
Yeah.
And when you feel that way, what's your motivation to exercise, right? What's your motivation to take the hummus out of the refrigerator instead of that glass of wine, right? You know, it's those decisions, right? That when we're functioning optimally, when we're our best selves, we make better decisions. And when our mood is low, we go for comfort and we don't necessarily make the right decisions. And so it's what we call multifactorial problem. You know, there's lots of factors that play into how our bodies age with menopause. And I think sometimes we don't think a lot about how low mood, even if it's not depression, affects our health because we make the wrong decisions when we're not feeling optimal, right?
Yeah.
So why not heighten that? Why not, you know, put our brain in a state where we're well enough to say, you know what, I'm going to choose this behavior. Or importantly, you know, the other way to maintain your brain health as you age is to be really social. So what we're doing right now, connecting with each other, I'm keeping track of the conversation, you're keeping track, our mood's lightened, friends release dopamine, you know, it's really good for our brain. When our mood's a little low, sometimes we don't want to interact with people. Even if we don't have clinical depression, we might say, oh, you know what, I just as soon watch Netflix or you know, Hulu or whatever. And so when you're not your optimal self, you make decisions about social interactions as well that aren't good for your brain, right?
Yeah.
So what we're saying is that it's not just depression, which is absolutely important to treat, but this idea of, you know, quality of life really has some important ramifications for the kinds of decisions we make.
That's so helpful. And it really makes a lot of sense. It's great. I love this. So, okay, you're pro SSRI, you're pro hormones. It's very important to do everything we can to keep our
for the right people. Yes.
For the right people. So yeah, then I'm going to go to two questions. Which
That's why you need some group like Alloy to tell you if it's right for you, right?
Yes.
I'm really cautious. I'm really cautious about, there's a movement now to recommend estrogen for everybody to prevent Alzheimer's disease. And as somebody who people associate with this idea in the scientific world, I'm much, much, much more cautious than those proponents who say everybody should be on it. You need to interact with a provider who assesses you on an individual basis. Women are undertreated across the globe for their menopause. But the other side of that is you don't want to put it in the water, right? So you need to interact with healthcare providers, with HOPE NAM certified menopause practitioners who've shown that they know how to treat women like Alloy does, and make sure that they're getting the right information for their own symptoms.
Absolutely. And I also just stuck in the chat, if you want to check out Alloy, and I'll say it again, use code REVEL25 at checkout for $25 off your first purchase. And Alloy is a telemedicine company where they prescribe hormone treatment and have the answers to all this stuff. So please check them out. So my question for you now is, how long can you stay on hormone therapy? That's a question that comes up a lot in our community, right? People tend to say like, not past 60, and you can't start it if you're in your late 50s, you should start it early. That's also something that I keep hearing different things. And also, what about the risks? Like, what if you've had breast cancer? Then obviously you can't do it, right? I'd love your thoughts on those two things.
Yeah, and those two ideas are tied. How long can you use it and what are the risks are tied together, because the risks associated with hormone therapy increase with age. So the older you are, the greater the increased risk of breast cancer with hormone therapy, for example, although that risk itself is much less than what people think, right? That idea is out there, but very, very few women are affected by that risk. So there used to be, following the publication of this big study called the Women's Health Initiative, which was the world's largest randomized trial of hormone therapy for the prevention of cardiovascular disease. And there was an Alzheimer's arm. That study actually showed some risks with this particular formulation of hormone therapy. And there was a rule that came up after that said, 5 years and you're done. the leading medical societies all got together and said, there is no stopping rule. There is no such thing as this 5 years and you're done rule. This is not a scientifically based rule. So you make the decision on when to stop based on what symptoms you have and based on how withdrawing from the hormone therapy affects your well-being, balanced by, the risks that are associated with certain formulations.
So you can just, you can just stop your hormones. It's not like taking like Effexor or something where you're not supposed to stop it. You could just stop your hormones and see how you feel for a week or two and then go back on. I've never stopped mine.
One can, yep. And about a third of women will re-experience hot flashes when they do that.
Oh, so but only a third. That's interesting.
But only a third, yep. About a third of women. And it depends on what age you withdraw from. But it is almost like a new menopause. So your candy neurons in your brain are readapting, to the loss of estrogen. So.
And more, is that same risk for depression there? I mean, estrogen withdrawal is sort of what I've been hearing is the thing that causes the depression. So, and that's why it's also more increased at postpartum. Right, same thing.
Exactly. And so if that's for some women. For some women. Now, remember in that study I described you that it was only the women who'd had the history of depression who, when you withdrew them from estrogen, had a recurrence of it. The women who hadn't had that history of depression during the perimenopause, when they were put on estrogen and withdrawn from it, they did not have depression. So there's this subgroup that you rightfully pointed to, which is the postpartum depression group as well. There's a subset of women for whom estrogen withdrawal triggers mood problems. It's reliable. And we think we know some of the mechanisms, some of the biological reasons why women are doing it. So you're absolutely right. For those estrogen sensitive women, when they withdraw from estrogen, it may very well trigger a depression. And I would say that in women with a history of major depressive disorder, which is 1 in 5 women, they in particular need to be very careful when they withdraw from the estrogen to make sure that they're monitoring their mood, that they have kind of a path forward to maintain their mood, like an SSRI, like CBT. Yeah.
All right, we're going to take a couple more questions from the audience before we go. What do you suggest for women who have estrogen positive breast cancer and who have had depression both before, during, and after menopause?
Yeah, such an important question. So breast cancer is a contraindication to hormone therapy because it actually exacerbates pre-existing disease. So you do not want to take hormone therapy if you have breast cancer. Vaginal estrogens appear to be relatively safe for women with breast cancer. So I want to put that out there, that there appears to be a different kind of recommendation for vaginal estrogens because they're not absorbed into the system. This is important for women with breast cancer because their anti-estrogen treatments lead to a lot of vaginal symptoms, and they're all oftentimes fearful about using vaginal estrogens because they've had this horrific experience with cancer. But that's something they should have an informed conversation with a NAM certified menopause practitioner about if that option's good for them. But the depression is SSRI. I would go for an SSRI or psychotherapy. In this case, when you have the pre-existing depression, it could be because the person has some of the many biological risk factors for depression that many of us carry, in which case, you want to, if you will, correct the chemistry, which one can do with SSRIs. That makes, a lot of sense. If the past history of depression, like for many of us, relates to negative life events, stressors, and that sort of thing, I also like to highly recommend, evidence-based cognitive behavioral therapy.
Yes.
Like I say, all the SSRIs in the world aren't going to help you overcome your fear of aging. All the SSRIs in the world aren't going to make you think better of your ex-husband.
Exactly.
So those kinds of contributors to stress into mood, they're best addressed through evidence-based psychotherapy. And there we want cognitive behavioral therapy or interpersonal behavior, which I will say rewires the brain, just like a medication does. You can look at before and after pictures
Wild.
of people in psychotherapy, and their brain responds differently. So it works.
I've often wondered why CBT isn't like taught in schools, like why kids aren't exposed to some of the basic, it just seems so useful.
Right, right.
Really, really work. And learning how to rewire your brain in certain situations and how to react differently. It seems so fundamental.
Right? It's like self-care, right?
It's like
it's self-care. You discover what bad paths your brain goes down when you encounter a stressor, and you just block off those paths. And once it's done, there's no withdrawal from that. You've re-taught your brain, right? It's not like a medicine where you're going to have this rebounding effect. CBT skills stay with you.
I totally agree.
Yeah.
I always feel like all these anti-anxiety medications and antidepressants, particularly for anxiety, they seem so good. But to me, depression, therapy is really useful. I'm a big fan of therapy.
Yeah, great. That's great to see. Yeah.
Makes a lot of sense. I wanted to ask you, actually, if someone's asking about the transvaginal creams, someone's saying some of the transvaginal creams have parabens that have been found in tumors. Please, what are the names of the temporary, not permanent transvaginal estrogen? And I wanted to follow up on that and say, I remember when I've used vaginal estrogen and they said it doesn't cross the skin barrier, is that the term, or that doesn't cross the membrane, but it seems like I don't really believe that. Is that really true? Like, how could it not? You're putting it.
It's absorbed into the system. So I think that's what you mean. Does it go beyond the vagina to other areas of the body? And it does, but in incredibly low levels.
I
like
see.
Really,
so
really
so low that
the absorption, as we say, into the circulation is very low.
Got it.
So that means it wouldn't necessarily travel to the breast. It also means it wouldn't travel to the brain. So you don't get the benefits of
You're
it.
not right. So if you take
brain.
Trace, it's not going to help the brain or the E string or something. It's just going to help your vagina. Be more, which is good.
And the creams, there I would talk to a NAM certified menopause practitioner about whether you want the vaginal cream to be estrogen containing, which I oftentimes recommend, because there are some changes to the vagina that don't improve if you treat it too late. Like, you can only treat to the point that you've reached and maintain where you are. So, treating vaginal symptoms early is really important. And it's only estrogen that will deal with the menopause-induced changes in the vagina. Now, some women don't have these symptoms and they're really looking for lubrication and lubricants and that sort of thing. And if you go to a really good NAM certified menopause practitioner, they'll even tell you the difference between different lubricants, the water-based versus silicone-based.
Yeah, some people like the hyaluronic acid ones. And
so I would, it's an important distinction. But if you want to change the physiology of the vagina, if you want it to actually change in its shape and in the way that it responds to the sexual stimulation, if one wants a more natural kind of lubrication, that sort of thing, that's where you want an estrogen. And having that conversation is important.
And whether it's cream or a suppository or a ring or all of those different things still do the same physiological improvements to the vagina.
But I've never heard anyone. I'm grateful to you for saying that if you don't catch some of these changes by a certain point, it is too late. Because Dr. Jen Gunter is so great and everyone loves her, and I've interviewed her and really like her. But I remember she once either wrote or said to me that use it or lose it was a myth. And I was like, is that really true? Because I see so much evidence of women who they've waited too long and they have to use dilators, they use dildos, they really have trouble having sex. And I feel like if they had been taking care of their vagina all along, this might not have happened. So I mean, maybe use it or lose it is but maybe it's you need to be paying attention.
Use it or lose some of it.
Use it or lose some of it. There you go.
Yeah, and I should say that the kinds of systemic hormone therapy that you're taking, like the pills or the transdermal, that one would be prescribed for vasomotor symptoms if one went to aloe, for example, that will take care of the vagina in most cases. And some women need something else, but a systemic estrogen will confer those benefits as well.
Great. And aloe, you guys sell all the different transvaginal stuff, all the vaginal creams?
So right now we've been around for 7 months, and we're so thrilled to be working with you, Nina, and with you, Pauline. But we, for now, we sort of started with our minimum viable product, which is a business term. So we're doing estradiol patch pill for systemic. Vaginal right now, we only have cream. We will be expanding our offering there. We also have the low dose paroxetine for those women who are experiencing hot flashes who are contraindicated for hormones. So
like
that's
Paxil? Is it?
It's not the same dose for a therapeutic, that it wouldn't have an effect on your depression, but it has been FDA approved to treat hot flashes, only hot flashes. It's the only, but it can be really helpful to those women who can't take estrogen. And we also, I just wanted to mention that we're really excited working with Pauline on a cognitive behavioral therapy offering to be rolled out in the near future, which is somewhat of a under wraps project, but we're really going for a pilot, working with a great colleague of Pauline's who the two, I don't know, Pauline, do you want to talk really for a minute about what
very exciting.
You guys worked on in Chicago? It was such a great, you were talking about evidence-based CBT, and I was just thinking about the postpartum women in Chicago.
Yeah, so we have been working for quite some time with telemedicine tools you can use on your iPhone to access evidence-based cognitive behavioral therapy modules. And we have an application called Sunnyside, developed by my really, really talented and lovely colleague, Dr. Jenna Duffasey, who's a clinical psychologist and a rock star app developer.
Cool.
And she merges the two of them together. And we have one that we tailored for women, Black and brown women in the South Side of Chicago that are served by our hospital, so that when they're pregnant and they want some assistance with their depression and anxiety symptoms, we can give them this free of charge. And we send them, we say there's, all of us have barriers to care, but it's disproportionately burdensome to women of color. And so we really want to think of innovative ways where we can get this technology and this help to everyone. So
that is amazing. You guys are going to do this at Alloy. I'm so excited.
I hope that Monica's not going to kill me for coming out with it, but it's just too exciting. We're getting really close, and I wanted to give a shout out to Pauline and Jenna, who've been just brilliant at this. And of course, I think you said in your intro, Pauline is one of the very talented doctors who sort of, what would you say, discovered or figured out how to diagnose perimenopausal depression in women, and how it's a specific sort of depression. And just quickly, I know we have to go, but I love that sort of, in my mind, it's a three-pronged chart, Pauline, that you've sort of talked me through about the various outcomes of the Sunnyside, like sort of the CBT outcomes were just as strong as the therapy ones, I think is and quicker than the SSRIs. I think it was a very powerful argument for the
they really are very concrete tools. Yeah, I think that's amazing. I can't wait to try it out. I was just telling a colleague the other day, a woman who's pregnant, and I was telling her that when I was 5 months pregnant with my twins, I went to the gynecologist and I was like, you need to commit me to Bellevue. I was so depressed. They put me on Prozac, but I mean, it's really an issue. Our hormones are really, I mean, that's why I'm grateful now to be like much calmer, but that's an amazing service that you're doing for those women. That's incredible. I'm so glad to have met you. All right, well, thank you. So to Dr. Pauline Maki and to Anne Fulenwider, so lovely to see you both. Everyone, please check out Alloy, myalloy.com. The code again is Revel25 for $25 off. Anne and her co-founder Monica run a group. They have regular support groups on Revel. You can find them anywhere. Just search for Alloy or search for Anne's name. And you can always write to them. They're members of the community. You can ask them questions. And hopefully we'll have Pauline on again, because you were just amazing.
Oh, I'd be happy to. What a great conversation. Thank you.
Particularly because medical care has gotten so bad lately, like so much worse. It's so fragmented. So to get answers is really helpful, because I feel like it's just impossible these days. Since COVID, it's really taken a nosedive. I don't know where we're going. So very glad to meet you.
We're going to
You
Alloy.
as well. We're
Going
going
to
to
Alloy.
Alloy.
Thank you,
Right,
Tina.
going to
and
Alloy.
Pauline.
Dancer. All right. Take care,
All right.
everyone. Good
Thanks.
night.
Be well.
Thanks,
all.
Tina.